Hello, everyone, and good evening, good morning for wherever you are on the planet. My name is Hugues de Lavallade. I'm a consultant hematologist at Guy's and St. Thomas's Hospital in London. And I will actually talk about the management of CML and give you an update on the most recent development. These are my conflict of interest. So as you all know, we've been quite lucky in the field of CML with quite a few tyrosine kinase inhibitors. We started with Imachni first, then we had second generation TKI with nilotinib, dasatinib, bosutinib, and then now we are emerging to have more third generation TKIs. Obviously, you all know ponatinib, but we also have many other coming, of course, as Simile, and then another couple of them who are actually going to be also of interest. So what is interesting with tyrosine kinase inhibitors is that they don't just target BCR-ABL, they also have lots of other targets, as you can see on this slide. And in addition to that, we also know that they have also off-target effects, which are also to be taken into account when it comes to both efficacy, but also side effects. And as you know, we really have to balance benefit and risk, of course, in this disease. Because if you just choose one of the most potent TKI like ponatinib, around a decade ago, there was a first-line trial using ponatinib versus imatinib in the first-line setting. And unfortunately, this trial had to be discontinued due to the cardiovascular toxicity of the drug. So again, it's not as simple as choosing the best TKI and putting that as a first line. So we also know that there is also the toxicity with the other tyrosine kinase inhibitors. And this toxicity is quite cumulative. This is an example of nilotinib, and then you can see, even after 5 years of exposure, you can see that the cardiovascular toxicity continued to increase. So obviously, cardiovascular toxicity has emerged as a very important aspect to take into account to choose TKI, whether it's for first line, second or third line, or later. But obviously, this is something that we have to balance out with the efficacy of each of these treatments. I think you're all very familiar with the ELN guidelines. They were recently updated 2 to 3 years ago. And obviously, warning of failure are what we're looking for and would be the reason for switching TKI. So if I just briefly give you an overview of how I treat CML and how I consider CML, we have obviously to consider that this is a very heterogeneous disease. On one hand, we've got the chronic phase, obviously, and then on the other hand, we've got a more advanced phase, and the treatment between the two entities varies tremendously. So on one hand, if you've got a patient with low or intermediate risk, obviously you would start with a TKI induction, and you would aim for obtaining all these milestones from the ELN guidelines, and then the patient would be a candidate for TKI discontinuation. On the other hand, we've also got the high-risk population, which now comprise high-risk SOCAL, INE-LTS score, de novo accelerated phase, but also patients with additional chromosomal abnormalities at diagnosis. And there is a continuum between this high-risk group and the more advanced phase. So this high-risk group obviously would be treated a similar way as intermediate and low risk, but you would really think twice before you would consider this patient for a TKI discontinuation. And if we look at secondary accelerated phase, those patients would also receive TKI if they respond to, and then what they would need a stem cell transplantation because they've actually shown secondary resistance. As for blastic phase, in the UK, we use Flagada plus TKI. We use usually a couple of courses, and then those patients proceed to an allogeneic stem cell transplantation. So as you can see, there's a very large variety and heterogeneity in this disease, and the treatment range from TKI induction followed by discontinuation for the lower and intermediate risk patient up to intensive chemotherapy followed by transplant for the more advanced phase. And of course, I've just put here a reminder of the ELN guidelines. Now, the other aspect we need to do is when it comes to CML diagnosis, we really want to try to stratify this patient the best we can. Obviously, we've got ELTS and SOCAL risk score, but we also want to determine which one are going to fare badly. And those ones who've got additional chromosomal abnormalities are our category that fares particularly badly. So we've been for some time using the old classification of the major root additional chromosomal abnormalities, but more recently there's been a couple of publications, one from the MD Anderson and the US in general, showing a risk stratification with which is much more refined. And in the high risk population, as you can see, the risk of progression to blastic phase is extremely high, and this includes obviously EVI1 rearrangement, monosomy 7, isochrome 17, and complex high-risk karyotype. This was also confirmed by the German study, which was done a few years ago as well. And as you can see, the high-risk population is not very dissimilar from the classification that was emerging from the US. So this is a very important tool when it comes to determining, to deciding on the first-line treatment, but also when it comes to monitoring the patients more appropriately in this situation. Now, when we move on to the third-generation TKIs, we have now two licensed drugs, ponatinib and asciminib. Asciminib is licensed in the US. It's licensed in some countries in Europe as well. And then there are a couple of other TKIs that may actually become licensed, hopefully in the next few years, vodobatinib and HQP1351, both of which also are quite interesting in terms of offering a larger variety of treatment for this patient. So if I start with asciminib, I think you're all very familiar with the ASSEMBLE trial, which was randomizing asciminib versus bosutinib in chronic phase CML patients who are resistant to at least 2 TKIs. And the superiority of asciminib was very well established, with a primary endpoint met at 24 weeks, showing an improved, a better MMR for the patient who received asciminib. Now, as you probably know, asciminib is now being considered and under trial for first-line treatment for CML patient in chronic infections. This is very exciting. There is some data from the Australian group that were recently presented at ASH, the ASCEND CML trial, including 100 patients in chronic phase CML, with a very interesting design of asciminib first line with a single arm asciminib, but with the opportunity to actually add in other TKIs in the case of failure, or to increase the dose of asciminib. And the safety profile was good, with obviously a good molecular response. And as you can see, in terms of the patient who discontinued asciminib, there were very few for resistance, and a few of them in terms of toxicity as well. So this is quite promising. I think the safety profile of asciminib is very interesting, and we will be looking forward to see the result of the ongoing first-line randomized trial with asciminib. When we look at the other third-generation TKI that is obviously licensed, ponatinib has been licensed for quite some time now, and I think you've all probably been using it quite extensively. Obviously, one of the issues with ponatinib was its cardiovascular toxicity, because its efficacy is remarkable. So the OPTIC trial, which was recently updated at the last ASH meeting, was giving quite an interesting update. I think you might be familiar with this design as well. So this patient were heavily pretreated patients randomized to ponatinib, 3 different dosage, 45, 30, and 15 milligram daily. And then upon achievement of a CCYR or a BCR less than 1%, their dose was reduced in order to try to avoid to limit its toxicity. So as you can see here, the patient included in this trial, in each of the arms had quite a number of cardiovascular risk factors, hypertension in 28% of them, and dyslipidemia in 15 to 20% as well. As you can see, this patient had been heavily pretreated with at least 2 TKIs, but half of them had actually received more than 3 or more TKIs. And again, if you look at the best response to the prior TKI, those patients were very resistant patients with complete hematological response only or worse, achieved in the vast majority of patients. So again, these were very resistant patients with multiple lines of TKI treatment. As you can see here, the efficacy of the 45 milligram arm was established with an excellent achievement of CCYR at 60% for the 45 milligram arm. What was very interesting is to see that this better response was particularly pronounced in those patients who had a T315I mutation. As you can see here, it was less pronounced for patients with other mutation, but still interesting for patients without a kinase domain mutation. And then when you look at the patient who actually had the worst response to the prior TKI, you could see that the 45 milligram was really very superior compared to the other two dosage. Finally, when it came to the adverse event, especially the arterial occlusive event, you could see that this strategy was actually reducing the risk of arterial occlusive event with an exposure-adjusted AOE rate, which was quite diminished. But again, you could see that the toxicity was actually even further limited by reducing the dose of ponatinib. So those patients who were on 15 milligram had a lower risk as well. But overall, this trial is a very important one and quite a milestone in the use of ponatinib, because now we can, using this design, limit its toxicity. So there are some other third generation TKI that are being looked at the moment. I think you may have heard of this HQP1351 TKI, which come from China. The MD Anderson has started a phase 1 and PK assessment for this agent using 3 different dosage. As you can see, the patients that were been enrolled in these are also heavily pretreated patients, some of which actually has prior resistance to ponatinib. And interestingly, if you look at, we specifically look at the patient who failed ponatinib, you could see that among the resistant patients, you do see quite a few patients achieving CCYR or even MMR. Now that has to be, of course, taken into account is the fact that there's very limited number of patients, but this might be actually a very promising agent. Its toxicity and its safety seems to be quite limited in the hand of our colleagues from the MD Anderson, as you can see here on the left-hand side, with mainly CK elevation, LFTs as well, lipase, and as major side effects. So, but obviously, this is a small trial so far, so we'll need to see when we have more patients treated in Europe or in the US. Now, finally, I'm just going to touch on vodobatinib, which is another third generation TKI. So it's a very selective one, as you can see here. It's a very selective one, as you can see here, and has especially a very low effect on VEGFR compared to ponatinib. Now, one important aspect is that it does lack efficacy on T315I, so therefore it's not a potential candidate for patients with T315I mutations. Nevertheless, this phase 1 and phase 2 trial have actually demonstrated its efficacy with the achievement of major synergistic response in those patients who were not already in CCYR, even in patients actually who had failed ponatinib. So this is another interesting agent, and in the years to come, we'll be lucky to have either we'll be lucky to have one of these two novel third generation TKIs. Now, the next question is trying to identify the poor responder at diagnosis, which is a very important aspect, obviously. And And obviously, what we want to try is to evolve into a more tailored medicine and be able to determine at diagnosis which patient will need treatment with more intensive, with more potent TKI. So there's been a recent, a very interesting data published by the German group from the Tiger trial, showing the impact of ASXL1 diagnosis on molecular response, and demonstrating that those patients who've got an ASXL1 at diagnosis, as you can see, this was the majority of patients found with mutation at diagnosis out of 222 patients in this clinical trial. And you could see that actually the rate of MMR 12 18 and 24 months was only 55, 60, and 65% in patients harboring an ASXL1 mutation at diagnosis versus 85, 89, and 89% respectively. So this is a very important first result and needs to be obviously confirmed, but this could actually be the beginning of using mutational analysis for other genes at diagnosis to try to determine the profile, the risk profile of each patient in terms of response to TKI. There was also another very interesting publication recently from the Australian group, again in a similar design, looking at mutations at diagnosis as well as Philadelphia-associated rearrangement. And as you can see, in patient where in MMR, 21% harbored one of these versus 70% of the patient who had a poor outcome. This was recently, this work from the Australian group has actually evolved into a bigger project, and they've just recently showed at ASH some very interesting data on the role of additional genetic abnormalities, including both cancer-related gene variant, but also Philadelphia-associated rearrangement. They looked at two of their cohort, one of the Imachni treated patient, 200 patient, and patient who received second-generation TKI, 163 patient. And they found actually a total of patients with additional genetic abnormalities of 31%, 34% in both groups, very similar. And again, the ASXL1 was the most frequent mutated gene, both in Imachni treated patient as well in second-generation TKI upfront. After that, TET2, RUNX1, and DNMT3 were also recurrently mutated. When they look at the impact on a failure-free survival, which basically take into account the ELN guidelines, i.e., the risk of hitting one of these failure or being in optimal response, you could see that actually those patients who had actually an additional genetic abnormalities at diagnosis had a lower failure-free survival compared to those one who didn't in the imatinib arm. This was very pronounced in the imatinib arm, but it was also noticed in the patient treated with second-generation TKI up front. Now, when they looked at the cumulative incidence of major molecular remission, this also held true, but only for the patient treated with imatinib first line. As you can see, it was very pronounced here, and even so in patient with MR4. Now, the very important aspect of ASXL1, I think, is its link with the potential of development of kinase domain mutation. And as you can see here in the same report from ASH, the Australian group showed that those patients who had an ASXL1 variant at diagnosis had obviously an even worse failure-free survival, but also were more likely to develop a kinase domain mutation in the patient who were treated with frontline imatinib compared to other mutation. And that makes a very nice link with the emergence of kinase domain mutation, because, as you know, this has been quite extensively looked at ever since imatinib was discovered. We've actually determined a number of kinase domain mutation and assess their sensitivity to the various TKI. And I think this link between ASXL1 and kinase domain mutation is a very important one, and one that actually may help in future to stratify and to screen those patients more frequently. So moving along to kinase domain mutation, we've done some work both in my group, but also in many other centers. And one of the interesting aspect of the kinase domain mutation is that you can detect actually low-level kinase domain mutation with novel technique. This is extracted from a publication we did more than a decade ago with a group from the Hammersmith, where you can see this is a patient which you can read the BCR transcript level here in blue, and here you can see in red the mutation VAF. The variant allele frequency. And as you can see, it was the responsivity data we did at that time, but what we found is that when the patient had doublet transcript level and lost CCYR, that's actually when the patient, that's when we could at that time detect kinase domain mutation using Sanger sequencing. But when we looked at using parasequencing, we could actually see that actually knowing this mutation, it could have been detected much earlier. And when you look at the time between the emergence of the loss of response, the loss of MMR, loss of CCYR and blastic phase, you could see that it was 12 months between the first detection of mutation and the patient losing that response and progressing to blastic phase. And the patient in question, in this instance, the patient had the E459K mutation, was treated with imatinib first line. So there is very little guidance as to how frequently the mutation should be repeated. There is guidance for sure among different groups as to when kinase domain mutation should be triggered. But the frequency of that has not been covered yet. We know that from the ELN guideline, for instance, that there are mutations that are more sensitive to TKIs, and these are the ones that have been actually recommended in the most recent version of the ELN guidelines. Now, as I was telling just a moment ago, the reason why we are very interested in kinase domain mutational analysis is because we now have a better way of measuring this mutation, and we're moving all from Sanger sequencing to NGS, which is a far more sensitive way of detecting mutation, and we can detect kinase domain mutation as low as 3% of VAF, and when the BC level also is transcript level are also pretty low. So this was a new recommendation from 2020, and recommending NGS for the use of kinase domain mutation based on the extensive publication from the group from Simone Severini, and the publication we did as well with my group. So if we look at the first publication from Professor Severini, as you can see, she had a fantastic trial called Next in CML, where she was looking in parallel through using Sanger sequencing and NGS. So the patient were actually failing or having warnings to ELN guidelines. And as you can see, there were only 25% of patients who were positive by Sanger sequencing, but you could see that there was 47% who actually had a mutation when it was looked at by NGS. And as you can see, there was also patients who had double mutation among the patients who actually were detected with one single mutation by Sanger sequencing. Now, the next question was, would this mutation evolve? And as you can see in this work from the same publication, she demonstrated that a patient who, for instance, was treated with dasatinib and had a F317L mutation and continued to be treated with dasatinib, this mutation would actually inevitably expand, as you would expect, until the patient actually was meeting the failure criteria. This is another example of with a T315 again on the patient treated with dasatinib at half dose, 50 milligrams as a third line. And there are many examples like that. What is interesting as well to see is the kinetics of this mutation. So we looked with my group as a small cohort of 121 patients, which we screened for using kinase domain mutation. And what we find is that those patients in whom we could detect low-level kinase domain mutation had a much higher risk of progression compared to those one in blue who didn't have actually such mutation. And as you can see, this translated into better progression-free survival in the patient who didn't have any kinase domain mutation identified by NGS versus those patients who had a mutation. What is interesting is that you can see there is quite a sharp drop at the beginning of this curve. And what we found, and we were quite surprised to find so, is that some patients really had a mutation detected by NGS as early as 3 months. And this was actually done when we could actually only access 41 samples from patients from that time point at 3 months. And as you can see, this group was slightly skewed towards a patient with higher risk, because 20 of these patients, i.e. half of them, actually had a BCR higher than 10% at 3 months. So i.e. they were actually failing the early molecular response timeline. So we find four patients with a kinase domain mutation at 3 months, and all of them actually progress, as you can see. Interestingly, 3 patients had a BCR below above 10%, but 1 patient actually had reached the EMR. So that actually led us to trying to continue to prospectively screen patients as early as 3 months using NGS for kinase domain mutation. And this is an example from another patient where in whom doing this prospective way we found a mutation. So this patient, for instance, was treated with nilotinib first line, had a high risk SOCAL score. had a very nice response within 3 months because the BCR-ABL was actually below 1%, so far below the 10% milestone you would expect. Nevertheless, we could actually find a small clone of E255K mutation at 4%. And when we received the next sample of a patient, the BCR-ABL had more or less plateaued, but the mutation E255K had jumped from 4% to 87%. And shortly later, by the time the patient was referred to me, the patient had actually developed also a T315I mutation and had lost CCYR. In blue, you can see that you can read the BCR transcript level, which had jumped to 5.9%. So this patient obviously was in a pretty bad situation with a very high-risk disease. This patient was switched to ponatinib to only 30 milligrams due to cardiovascular risk factors. But as you can see, the response was quite rapid. And then the patient actually went on further to achieve an MR4, at which stage the ponatinib was reduced to 15 milligrams, and this patient has last follow-up remained in MR4 and close to MR5 actually. So this is quite a good story, and it shows you what you can do when you try to do early intervention using NGS. So that's probably one of the ways of using NGS is to try to identify those mutations very early on. We looked at prospectively into the trial from Frank Nicolini and the LMC group as a part of the collaboration. This is from the PETALS trial, the design of which is here summarized. This is frontline. This was a frontline trial of nilotinib versus nilotinib with speculative interferon. Out of this cohort, we checked. We looked for kinase domain mutation using NGS in 96 patients. And after 3 months, we could again find 3 patients who had a mutation by next generation sequencing. We found a T315I in 1 patient and a Y253 in 2 patients, although the BCR-ABL level were very low at 0.039 and 0.05, which is again extremely low for just a 3 months response. I'm going to show you these couple of cases because they are quite of interest. So this is the first patient. The BCR-ABL was 55% at diagnosis, dropped to 0.05% after 3 months. And we could find a Y253H, which was a predominant clone at 100%. So again, very early on, a mutation at 3 months. So as you can see, the patient remained in MMR for some time and then finally lost response and was taken out of the trial. There's another patient who had a very similar story and situation with a drop of BCR-ABL below the MMR threshold as early as 3 months, again on nilotinib first line. And this patient sadly progressed very rapidly to blastic phase. So again, you can see there are very different patterns, but what is important to note is that actually, if there is a mutation detected at 3 months, this is a very, very poor prognosis and could actually lead to very rapid progression to blastic phase or to a less rapid loss of response. After 6 months, we continue to screen this patient. We found kinase domain mutation in 8 patients. And what is important again is that 5 of these patients were actually in optimal response at month 6 with a BCR-ABL below 1%. Again, these are a few examples. This is an example. This is one of these patients who's achieved actually a CCYR, so a BCR-ABL below 1%, so far below the 10% milestone, and with undetectable mutation at 3 months, but a Y253H at 6 months at a very low VAF, 18%, with a very low BCR-ABL transcript level at 0.24%. And this patient actually lost response, as you can see. I've put here on the right-hand side the sensitivity for NGS and Sanger. With Sanger sequencing, you can only detect clones that have a VAF of 20% or above, but if the clone size is below 20%, you can only detect this through NGS. And this is another patient with a T315I. As you can see, this patient had a very low level of T315I, and it took actually quite some time for the T315I to become the predominant clone. And the pattern we've seen so far is that once the mutation becomes a predominant clone, that's the time when actually we see a rise in the BCR-ABL and the patient loses response. So finally, in a landmark analysis, we found that actually those patients who had a mutation detected at 6 months had a worse progression for event-free survival. So finally, I'm just going to address another question, which is quite important, and I mentioned before, which is the frequency at which we should actually be performing kinase domain mutational analysis. And as you can see, this is a young patient with very high risk SoCal score who was treated with nilotinib first line, and we couldn't detect any mutation using NGS. We were obviously very worried because of the fact that the patient was not reaching the milestone. So ND stands for not detectable. As you can see, we could not detect the mutation at 3, 6, and 10 months. So the question, which is more rhetorical, would you have performed another analysis when we saw actually that the BCR was dropping down to 1.2%? Well, in effect, we did one, and this is what we found. We found 3 mutations, F359V mutation at 13%, T155I at 4%, and Y253H at 4% as well. So very low VAF of these 3 mutations. These mutations actually were all below the 20% clone size that would make them detectable using Sanger sequencing. So none of them would have been detected by Sanger sequencing, obviously. And as you can see, this patient had 3 different mutations, all of which were actually conferring resistance to nilotinib. So as you can see, this mutation actually rapidly expanded, and the F359V mutation became much higher percentage, 49%. So obviously would have been detected by the Sanger sequencing. But again, the T155I and the Y253H were still at 9% and 8% respectively, which would not have made them detectable by Sanger sequencing, as I show you that. Sorry, as it's shown on this diagram. So we treated that patient with ponatinib, and this patient achieved MMR, and luckily enough, this patient has maintained that MMR, but with a high dose of ponatinib and also the use of Pegasus in order to deepen the response. Finally, this is the last example of a patient in whom we could change the outcome. So this is a patient with high risk and additional chromosomal abnormality at diagnosis, achieved CCYR. We could not detect kinase mutation, which we were screening for him because of the high risk disease. That being said, he had a rise in his BCR to 1.5% around 18 months. We need a kinase domain mutational analysis. We found a V299L mutation, which also conferred resistance to the dasatinib. And when we look backward, we could actually pull out this patient, we could find the mutation in those previous sample. The reason why we didn't do that at that time is because the patient had achieved MMR, and we usually did not at that time do kinase domain mutational analysis by NGS because of the lack of sensitivity. This patient did well on ponatinib, and they're still doing well. But let me just show you and explain you what are the limits of the NGS. So we believe that actually NGS can detect kinase domain mutation as low as a BCR of 0.1%. When the BCR is below 0.1%, it becomes more challenging. And for that reason, there is some hope that the novel assay developed by Professor Simone Soverini from Italy may actually increase the sensitivity of kinase domain mutational analysis, perhaps even below 0.1% of BCR-ABL transcript level. So this is just to show you that this patient had a durable response, like the other 2 patients that I've shown you examples of. So in order to try to summarize, first, we have an increasing number of third-generation TKIs, and the choice of third-line treatment remains still dependent on comorbidities, but also mutational profile and degree of refractoriness. But we're very lucky to have this agent. Ponatinib vascular toxicity, as we've seen, can be reduced significantly by dose reduction according to the optic regimen. And I think this is really a very important advances in the use of third-generation TKIs. And as we have more third-generation TKIs, we need to really understand how to use each one of them and what is the best setting for each of them. The cardiovascular toxicity, as you can see, remains a major factor to decide on the optimal treatment, whether it's for patient refractory or patient for first-line treatment. It's very interesting and it's very exciting to see that there's Simile, which is obviously a third-generation TKI that will be that is being used currently in a randomized trial as a frontline treatment, because this is obviously something very exciting and important to try to reduce the risk of progression. And finally, I think the predictors for response using mutational screening for genes such as ASXL1 seems to be a very promising tool to try to do a more tailored first-line therapy, but also to try to monitor this patient more closely and also to look for the emergence of kinase domain mutation. Because as we've seen, the ASXL1 mutation can also predispose patient to have more mutation, but also kinase domain mutations as well. So between all with all these tools, I really hope that we'll be able to evolve into a more tailored medicine and be able to stratify those patients from diagnosis and continue to have and then try to use even more so monitoring for kinase domain mutation at low level as well. And with that, I thank you for your attention. I'd like to thank all my co-workers, Professor Claire Harrison at Guy's and St. Thomas's Foundation Trust, Dr. Patrick Harrington, who is heavily involved in CML research, Dr. Deepti Radia, but also all our international collaborators. Thank you very much. So I don't know if there are questions in the audience. Okay. Excellent. So first question, how often and when should tyrosine kinase domain mutation by NGS be done? Should we wait to loss of response to change therapy if still in good response? So that's a very interesting question and one I didn't cover. So thank you for asking this excellent question. So because we have a more sensitive tool and as we've seen, it's very important to be able to intervene early on when it comes to revert the prognosis of kinase domain mutations. At the moment, using NGS is the right tool, but probably, trying to start screening patients who've got high-risk disease might be a way forward. And I hope that in the years to come, we'll be able to evolve into that. Especially, for instance, if we've got a novel marker like ASXL1 at diagnosis, those patients should definitely have a more frequent kinase domain mutational analysis by NGS. Obviously, this is limited by the funding aspect, but I think as those technology become more available, we should try to do more, but especially in those patients who we know are high risk, whether they are high risk ELTS, high risk so-called score, all got ASXL1, for instance. So hold on, I'm just trying. So discovery by NGS of cheap mutation like DNMT3 ASXL1, should we do something with them? So I guess, this comes back to the previous question as well. I really think that, and I really hope that we will all be doing in the next few years, diagnostic of mutation at diagnosis, such as ASXL1, DNMT3, and so on, because this is definitely very important for risk stratification, as we've seen. I've got another question. Chloroquine or hydroxychloroquine contribute to reducing the dose of ponatinib, reducing adversive without reducing efficacy. What do you think? I've not actually used a ponatinib in combination with either of these agents, so I'm afraid I won't be able to answer that question. I'll wait for. Okay, well, if there are, oh, there might be more. We've just got another question, very interesting. So when and how to use the interferon in combination with TKI? Very interesting questions. Well, I've shown you an example of a patient who was, having 3 kinase domain mutation, was very much leading, was very much leaning towards a stem cell transplant if we had not salvaged him with ponatinib. But as you can see with ponatinib 45, it was just hovering around MMR. So I would say in those refractory patients, I would tend to use pegylated interferon actually to try to deepen the response, especially when it comes to combining them with third-generation TKIs. However, there is actually no data or not much publication on that aspect. So But that's my practice in the context of very refractory patients. Got another question. So how frequently do you see kinase domain mutation? Is NGS necessary for identification of this mutation? Thank you for this question. So we do see kinase domain mutation mainly in those patients who have high risk SoCal score, who've got high risk features basically, or who've got of course additional chromosomal abnormalities. So basically, I would focus on this patient group essentially, and we see, as I said, a much higher incidence of this. But roughly, those patients who do not achieve an optimal response, on average, they would have between, as we said from the data from Professor Saverny, between 25 and 45% chance of having a mutation. Again, 45 being with NGS in the patient who actually fail according to the ELN guidelines. And the second question about whether it's important to use NGS, the answer is absolutely yes. Because again, there are many mutations that are below 20%, but also more importantly, if a patient has one mutation detectable by Sanger sequencing, there is also a fair chance that there might be other mutations in the background that are not being detected by Sanger sequencing and below 20%. So therefore, NGS is very much a preferred technique to screen for kinase domain mutation. So next question, SXL1 is important in ET, primary or secondary myelofibrosis. What therapy could reduce bone metastasis? Very interesting question. There's been no trial. I think this is just the emergence of, I think we're just starting now to realize how important it is to look for mutation other than kinase domain mutation in CML patient at diagnosis. So it will be very interesting to see actually, and I'm sure there will be clinical trials in the years to come using indeed more other combinations in view of this new landscape. Is CD26% inmersion a better indicator for patients who will achieve a prolonged TFR? That's still something that is, as far as I understand, still being actually looked at. The data is, the jury is still out, so I think we'll have to wait for a few more groups to work on that subject. I think I've answered all the questions. Okay, so if there are no more questions, I'd like once again to thank you for your attention. And please, by all means, don't hesitate to send me a question by email. You've got my email as a first on my first slide. So please don't hesitate. And I wish you a great day or a great evening for those who have been following us. Thank you again for your attention. Goodbye now.